First, we'll discuss about hypokalemia. We'll discuss about the causes of hypokalemia. Hypokalemia can be due to decreased intake, starvation or clay ingestion. We should rule out decreased intake. Then, most important is redistribution. Extracellular or intracellular shift of potassium is called redistribution. If there is intracellular shift of potassium, that causes hypokalemia. In redistribution, one is alkalosis. Acid-base disturbance, metabolic or respiratory alkalosis can cause hypokalemia. What is the mechanism? In alkalosis plus potassium ATPase action. So in alkalosis, less hydrogen ions in the serum. So HK ATPase enzyme causes hydrogen ion movement from cells to serum. Then there will be inward movement of potassium into the cells. So in alkalosis, the enzyme is hydrogen potassium ATPase. More hydrogen ions will come out of the cell and potassium will move inside the cell. That causes hypokalemia. Then increased sodium potassium ATPase activity. Hormonal causes. Increased sodium potassium ATPase activity. What is the action of sodium potassium ATPase? During depolarization of cell, there will be more sodium entry into the cell. After depolarization, with sodium potassium ATPase activity, the sodium will come out of the cell to potassium will enter into the cell. If there is increased sodium potassium ATPase activity, more potassium will move inside the cell. That causes hypokalemia. Important cause is insulin. Insulin increases activity of sodium potassium ATPase. That is the mechanism for hypokalemia during insulin administration. Increased beta sympathetic activity. In emergencies like acute myocardial infarction, head injury, alcohol withdrawal phase, thyrotoxicosis, in all these situations there will be increased sympathetic activity. That can cause transient mild hypokalemia. Okay, if you treat that situation with potassium chloride, once the episode is over, there can be rebound hyperkalemia. We should rule out this high sympathetic activity. And sympathomimetic drugs, bronchodilators, tocolytics, ritodrine, they will increase sodium potassium ATPase activity. Other causes, alpha antagonists, thyrotoxic periodic paralysis, there will be increased sodium potassium ATPase activity. Or downstream stimulation of sodium potassium ATPase activity by caffeine, theophylline, the xanthine mediated stimulation of sodium potassium ATPase like caffeine, theophylline, or with ephedrine and pseudoephedrine in cough syrups, they can stimulate sodium potassium ATPase activity. Increased sodium potassium ATPase activity, hormonal causes like insulin or beta sympathomimetic causes, increased beta adrenergic activity, beta agonists, alpha antagonists, or thyrotoxic periodic paralysis, or downstream stimulation of xanthine mediated ATPase activity. And increased anabolism also can cause hypokalemia. For example, folate or B12 administration for the anemia. So there will be increased RBC production. There will be utilization of potassium by the cells. So increased anabolism can cause hypokalemia. There will be increased utilization of potassium by the cells, or GM-CSF administration, granulocyte monocyte colony stimulating factor administration. So increased leukocyte growth, neutrophil growth, that can cause hypokalemia. Folate B12 administration for anemia, GM-CSF administration for neutropenia, or TPN, total parental nutrition, they can cause hypokalemia. In all these situations, the mechanism is redistribution, transcellular shift of potassium. So acid-base disturbance, alkalosis, or these hormonal causes. Then anabolism. Should always rule out pseudo-hypokalemia causes. Other causes are pseudo-hypokalemia and even familial periodic paralysis or with barium intoxication. With barium intoxication, leak potassium channels are inhibited. Leak potassium channels in the cell. Leak potassium means potassium will come out of the cell. There will be leakage of potassium from the cell. With barium toxicity, that leak potassium channel will be inhibited. That can cause hypokalemia. When hypothermia can cause hypokalemia. With hypothermia, there will be hypokalemia, and during rewarming phase, there can be hyperkalemia. So other causes like pseudo-hypokalemia causes, familial periodic paralysis. The cellular mechanism is different in familial periodic paralysis when compared to thyrotoxic periodic paralysis. Then hypothermia, barium toxicity, inhibition of leakage channel. Then increased secretion of potassium, non-renal loss of potassium, either gastrointestinal loss, especially with bicarb diarrhea. Diarrhea, there will be bicarb loss and potassium loss, gastrointestinal loss and integumentary loss from sweating. So there are non-renal losses of potassium. Then renal loss. Renal loss, one mechanism is any condition causing increased flow or increased solute delivery to distal tubule can cause hypokalemia. Increased solute delivery to distal tubule. If there is increased sodium entry into the distal tubule, then there will be activation of inoc channels. More sodium will enter into the cell and aldosterone stimulation that causes potassium secretion. So increased sodium entry into the distal tubule or increased flow into the distal tubule, they can cause hypokalemia. Then important causes of renal secretion are mainly aldosterone mediated. So increased mineralocorticoid activity. So increased aldosterone levels can be due to primary cause or hereditary cause or secondary cause. Primary hyperaldosteronism, adrenal gland, the cause mainly in the adrenal gland. Primary hyperaldosteronism, aldosterone tumors, adrenal gland adenoma, or primary or unilateral adrenal hyperplasia, idiopathic or bilateral adrenal hyperplasia, adrenal carcinoma. These are primary adrenal gland causes. Adenomas, hyperplasias, and adrenal carcinomas. They are primary causes. Then coming to hereditary causes, familial hyperaldosteronism. There are 3 types of familial hyperaldosteronism and congenital adrenal hyperplasia. In the primary, adenomas, unilateral or bilateral hyperplasias and carcinomas. And in secondary causes, what are the secondary causes of hyperaldosteronism? Hypovolemia can cause secondary hyperaldosteronism, malignant hypertension, renal artery stenosis, renin secreting tumors. These are causes of secondary hyperaldosteronism. Even Cushing syndrome, aldosterone levels are high. Even Bartter syndrome, Gitelman syndrome. What is Bartter syndrome? In the thick ascending limb of loop of Fenel is the lumen cell. In thick ascending limb of loop of Fenel, NK2CC channels are inhibited in Bartter syndrome. So there will be natriuresis. Natriuresis means increased availability of sodium in the distal tubule. More increased sodium entry into the distal tubule. That will stimulate inoc channel activation, sodium entry and potassium secretion. And in Bartter syndrome, loop diuretic action also NK2CC inhibition. What is Gitelman syndrome? In the distal tubule, there are NCC channels, sodium chloride channel. Here in Gitelman syndrome, sodium chloride channel is inhibited. This channel action is absorption of sodium and chloride. So if absorption is inhibited, again there will be more sodium entry into a distal tubule. Natriuresis is more common with loop diuretic. Loop diuretic is more effective than thiazide diuretic. But hypokalemia is more common with thiazide diuretic. The reason is here with the thiazide diuretic, with inhibition of NCC channel, there will be decreased absorption of sodium. So there will be more sodium entry into distal tubule. These inoc channels are very nearer to the distal tubule NCC channels. Whenever there is decreased absorption of sodium, immediately principal cells are present in the distal tubule. There will be sodium retention and potassium secretion. So in the downstream, there are epithelial channels, inoc channels, and the principal cell, they are nearer to the NCC channels. Almost both are in the distal tubule. So there will be immediate effect of the sodium retention and potassium secretion. That is one mechanism. Second mechanism is there will be hypercalciuria with loop diuretics. Calcium secretion will be high with loop diuretics. That calcium inhibits inoc channels. Okay, calcium secretion is less with thiazide diuretics. With thiazide diuretics, there is no inhibition of inoc channels by the calcium. So inoc channel activation will be more with thiazide diuretics. That cause hypokalemia is more with thiazide diuretics. Then one is increased aldosterone activity. Second one is apparent mineralocorticoid excess. Apparent mineralocorticoid excess. One cause is genetic inhibition of 11-beta hydroxylase. Genetic inhibition of 11-beta hydroxylase. Even normally cortisol has mineralocorticoid activity, but 11-beta hydroxylase enzyme, it converts cortisol to cortisone. In the kidney tubules, enzyme converts cortisol to cortisone. Cortisone, it doesn't have much mineralocorticoid activity, but with inhibition of 11-beta hydroxylase, there will be more cortisol accumulation. There is no conversion from cortisol to cortisone. So that cortisol has mineralocorticoid activity that can cause sodium retention and potassium secretion. It's apparent mineralocorticoid excess. There is no increase in aldosterone levels, but inoc channel is activated because of cortisol activity. That cortisol to cortisone conversion is inhibited because of deficiency of 11-beta hydroxylase. So there is genetic inhibition of 11-beta hydroxylase, that is called same syndrome of apparent mineralocorticoid activity. And second one is inhibition by carbonexolone, some drugs, carbonexolone, licorice, glycyrrhetinic acid, glycyrrhizinic acid. They are food additives. Glycyrrhizinic acid is a sweetener that will inhibit 11-beta hydroxylase. Glycyrrhetinic acid like ricinic acid, carbamazepine, licorice, fooded to some drugs, tobacco products, they will inhibit 11-beta hydroxylase. In all these conditions, there will be apparent ventricular excess. There will be increased cortisol levels. Mechanism is inhibition of 11-beta hydroxylase. What is Liddle syndrome? Upregulation of ENaC channels. Genetically, there is upregulation of ENaC channels. That will cause again sodium retention and potassium secretion. And other mechanism is increased non-reabsorbable anions in the distal tubule. Non-reabsorbable anions, increase the delivery of non-reabsorbable anions into the distal tubule. One example is, classical example is with vomitings and nasogastric suction. HCl is lost. There will be loss of chloride ions. That causes accumulation of bicarbonate. That causes metabolic alkalosis and accumulation of bicarbonate. Increased bicarbonate causes increased filtration, bicarbonaturia. That bicarbonaturia, increased bicarbonate into the distal tubule, again that causes potassium secretion. So non-reabsorbable anions like penicillin derivatives like penicillin, naphthalene, dicloxacillin, tecarcillin, oxacillin, carbenicillin, all these penicillin derivatives are non-reabsorbable anions. So increased non-reabsorbable anions in the tubules, they cause increased secretion of potassium and hypokalemia. So vomitings, nasogastric suction, even proximal RTA, proximal renal tubular acidosis. What is the mechanism in proximal renal tubular acidosis? Type 2 RTA. Inhibition of bicarb absorption in the proximal tubule. Then that causes increased bicarbonaturia, increased bicarbonate into the distal tubule. Even DKA also, diabetic ketoacidosis, increased ketones in the urine, or even glue ingestion, toluene toxicity, hippurates, all are the non-reabsorbable anions in the tubule. They will cause increased secretion of potassium. And magnesium deficiency will cause hypokalemia. What is the mechanism? Here there are two potassium secreting channels. One is ROMK, renal outer medullary potassium channels. Potassium is secreted into the lumen. And other channels are BK channels, big potassium channels. Most important is ROMK channel. The ROMK channel is inhibited by magnesium. ROMK channel is potassium secretion into the lumen. Magnesium inhibits ROMK channel. So if there is magnesium deficiency, there is no inhibition of ROMK channel. So there will be more potassium secretion into the lumen. So magnesium deficiency will cause hypokalemia. Diuretics will cause magnesium deficiency and hypokalemia. These are causes of hypokalemia. Now, how do you approach a patient with hypokalemia? What is the normal range of potassium? 3.5 to 5.5. If there is hypokalemia, immediately look for serious clinical manifestations or ECG changes. If there are significant ECG changes, directly treat low potassium hypokalemia. Don't waste your time by evaluation of other electrolytes or urine potassium level. There are many tests to know the etiology of potassium. So immediately you should correct hypokalemia. If there are ECG changes, there is severe hypokalemia with ECG changes, directly manage potassium. So if there are no serious changes, you rule out pseudo hypokalemia first. Then look for redistribution causes, intracellular shift of potassium. So if you manage the cause, if you treat the cause, hypokalemia will be corrected. We need not give IV potassium chloride aggressively. What are those causes? Insulin, increased catecholamine activity, acute myocardial infarction or alcohol withdrawal, thyrotoxicosis or head injury, increased sympathetic activity. Beta agonists like bronchodilators, tocolytics, alpha antagonists are in thyrotoxic, periodic paralysis patients, and caffeine stimulation or increased anabolism, even chloroquine, they can cause intracellular shift of potassium. So look for those redistribution causes. Then you treat the underlying cause. Then check urine potassium, milliequivalents of potassium per gram of creatinine. If kidney function is normal, if there is hypokalemia, will conserve potassium. So urine potassium will be less than 13 milliequivalents per gram of creatinine. This is urine potassium creatinine calculation. Urine potassium by creatinine calculation. Less than 13, it is less than 13 milliequivalents per gram of creatinine. So less than 13 means renal function is normal. So cause is extrarenal loss. So what are the extrarenal causes? Then check ABC, acid blood gases. If patient has metabolic acidosis, hypokalemia with metabolic acidosis, then cause is diarrhea, bicarb loss and hypokalemia in diarrhea. Patient has metabolic acidosis, probably patient has diarrhea with bicarb loss. Patient has alkalosis, vomitings, or profuse sweating. With profuse sweating, there can be normal pH or alkalosis. So if it is less than 13, look for extra-renal cause. If it is more than 13 milliequivalents potassium per gram of creatinine. Otherwise, you can check directly spot urinary potassium. So less than 20 milliequivalents, 20 to 30 milliequivalents means extra-renal loss. If it is more than 20 to 30 milliequivalents means renal cause. So if there is renal loss, then we can check TTKG, transtubular potassium gradient. Formula is urine potassium into serum osmolality divided by serum potassium into urine osmolality. So in hypokalemia, it is usually less than 3. In hyperkalemia, it is more than 8. Transtubular potassium gradient. So if it is less than 2, means the cause is osmotic diuresis. Less than 2 causes osmotic diuresis. If it is more than 4, then check BP, patient's volume status. If BP is high, hypokalemia with high BP, means hypervolemia with hypokalemia, means main mechanism is aldosterone mediated. High BP, sodium retention causes sodium and water retention, they cause hypervolemia and high BP. So in hypokalemia patient, there is renal loss of potassium, spot urine potassium more than 20 to 30 milliequivalents, or loss is more than 13 milliequivalents per gram of creatinine, that indicates renal loss. So hypokalemia, renal loss, high BP means aldosterone mediated. So because increased renin-angiotensin activity, increased RAS activity. Then check aldosterone levels. Aldosterone is high and renin is high. So if aldosterone is high, check renin levels. If renin levels are high renin is the mechanism, underlying mechanism. High renin means look for renal artery stenosis, is the most important mechanism. Renin secreting tumors, malignant hypertension or estrogen excess, they all can cause increased renin. Increased renin causes increased aldosterone. Increased aldosterone causes sodium and water retention, high BP, potassium secretion, so renal potassium loss and hypokalemia. Then increased aldosterone, but renin is low. So aldosterone is high, renin is low. We should always check aldosterone-renin ratio. If it is more than 50:1, that indicates main primary adrenal cause. Primary adrenal cause, aldosterone level will be high, renin level will be low. So if aldosterone is high and renin is low, it means the pathology is in the adrenal gland, cause is in the adrenal gland. There is increased stimulation of adrenal gland. If there is increased release of aldosterone, there will be negative feedback inhibition of renin. So what are the causes? Increased aldosterone, low renin. Primary adrenal gland causes like tumors, adrenal adenomas, hyperplasias, carcinomas, or familial hyperaldosteronism causes. In secondary hyperaldosteronism, what happens to renin levels? Secondary hyperaldosteronism means with hypovolemia. With hypovolemia, there will be increased renin stimulation. Then that causes increased aldosterone. So BP is high, but aldosterone is low. What are the possibilities? There will be apparent mineralocorticoid excess, like same Liddle syndrome of apparent mineralocorticoid excess. What is the mechanism here? In same genetic inhibition of 11-beta hydroxylase. Mechanism of Liddle syndrome, ENaC channel activation, and inhibition of any condition causing 11-beta hydroxylase inhibition. Other causes, licorice, carbenoxolone, other causes. So we have to differentiate same from Liddle syndrome. Why? It is more important in the management. The cause is same, syndrome of apparent mineralocorticoid excess. What drugs you will give? In Liddle syndrome, what drugs you will give for the management of hypokalemia? So which drugs inhibit ENaC channels? Which drugs act on ENaC channels? Amiloride. Amiloride is a classical drug. Okay, amiloride, trimetrine, trimethoprim, pentamidine, okay, nefamostat. These drugs, they will inhibit ENaC channels. What drugs act on aldosterone? Aldosterone receptors, spironolactone, eplerenone, drospirenone. They act on aldosterone. They are aldosterone receptor inhibitors. Low aldosterone, then check cortisol levels. If cortisol levels are high, that indicates Cushing syndrome. If aldosterone is low, check cortisol levels. If cortisol is high, the cause is Cushing syndrome. If cortisol is normal, then you look for these causes. Syndrome of apparent mineralocorticoid excess, Liddle syndrome, or other conditions inhibiting 11-beta hydroxylase. So in same and Liddle, what happens to aldosterone level? In Liddle syndrome, in the ENaC channel activation, there is sodium retention. There is increased sodium retention or decreased aldosterone levels. With Inact-channel activation, that is the main mechanism. As in Liddle syndrome, there will be decreased aldosterone production, decreased urinary excretion of aldosterone levels. Urinary aldosterone levels will be low. Even serum aldosterone levels will be low. The most important is for potassium secretion. Name 2 factors which influence potassium secretion. Important factors are potassium level in the blood, hyperkalemia, and aldosterone. So 2 important factors which influence potassium secretion is hyperkalemia, potassium level, then aldosterone. Important factors mediate aldosterone levels. What are the 2 important factors which mediate aldosterone secretion? Angiotensin. One is angiotensin, second one is again potassium. If potassium is high, there will be increased aldosterone secretion to decrease potassium level. That promotes potassium secretion. So 2 important factors which increase aldosterone which influence aldosterone secretion are again potassium level and angiotensin. So important factors for potassium secretion are again potassium level and aldosterone level. So what ECG changes you will find with hyperkalemia or with hypokalemia? In hypokalemia, what changes you find? So U wave, prominent U wave up to more than 1 millimeter, you can, or decrease in T wave, low amplitude T waves. Then ST, what are other changes in hypokalemia? Prominent U wave and diminution of T wave, and most important is QT prolongation with hypokalemia. You can have ST depression and QT prolongation. But QT STD changes can be present in many conditions. For example, digoxin can cause STD changes. Even left ventricular hypertrophy, there will be STD change. We should rule out those causes. And QT prolongation can occur with not only with hypokalemia, even with hypocalcemia, hypomagnesemia, even drugs. There are many drugs that can cause QT prolongation. We should rule out those causes. So prominent U wave, diminution of T wave, ST depression, and prolongation of QT interval. So there is increased spot urine potassium is high. There is increased renal loss of potassium. If BP is high, next step is we will check aldosterone level. If aldosterone is high, we will check renin levels. If aldosterone is low, we will check cortisol levels. Cortisol is high, indicate Cushing syndrome. Okay, if cortisol is normal, we will look for same Liddle and other causes inhibiting down beta hydroxylase. Okay. Suppose if BP is low, hypovolemia. If BP is low, then again check whether there is metabolic acidosis or alkalosis. Low BP with metabolic acidosis. Hypokalemia, increased renal loss of potassium, spot urine potassium is high, hypovolemia, low BP, and there is metabolic acidosis. Most important are renal tubular acidosis, proximal renal tubular acidosis, distal renal tubular acidosis, diabetic ketoacidosis. So proximal renal tubular acidosis mechanism is decreased absorption of bicarbonate. There will be bicarbonaturia that causes acidosis, metabolic acidosis. Even drugs like estrozolamide, topiramate, they will cause proximal RTA. Distal RTA, what is the mechanism? More H plus is the secretion, renal tubular acidosis. There will be secretion of potassium and accumulation of hydrogen. So hydrogen potassium ATPase, the main mechanism is again hydrogen potassium ATPase, increased hydrogen accumulation and increased secretion of potassium. That causes distal renal tubular acidosis. Drugs causing distal renal tubular acidosis are amphotericin, ifosfamide, amphotericin. There are many conditions like autoimmune diseases, sickle cell, SLE, Sjogren's syndrome. There are many conditions which cause distal RTA. DKA, there will be metabolic acidosis. What is the mechanism for hypokalemia in DKA? There are many mechanisms. So there are more ketones. There are more ketones in the distal tubule. So non-reabsorbable anions that can cause potassium secretion. And with insulin administration, there will be hypokalemia, increased sympathetic activity. So we should look for non-reabsorbable anions, means we should rule out penicillin derivatives, administration of penicillin derivatives, other means toluene toxicity, hippurates. We should rule out those conditions. So low BP with metabolic alkalosis. The patient has hypovolemia and metabolic alkalosis. So hypokalemia, increased, the mechanism is increased renal loss of potassium, low BP, hypovolemia, and metabolic alkalosis. Then check urine chloride. This is the most important step. If urine chloride is less than 15 milliequivalents per liter, means causes in vomitings. In vomitings, nasogastric drainage, there will be HCl loss and urine chloride will be low. There will be bicarb accumulation and increased bicarbonate in the distal tubules, bicarbonate urea. That bicarbonature causes increased potassium secretion. That's why we mentioned even in the renal loss of potassium also. This is mainly extrarenal cause. Vomiting, nasogastric drainage means extrarenal cause. But in the renal tubules, because of high bicarbonate, means bicarbonature, there will be increased potassium secretion. In those situations, urine chloride will be low, less than 15 milliequivalents per liter. If urine chloride is high, more than 20, then check urine calcium by creatinine ratio. Urine calcium by creatinine molar ratio. Okay? If urine calcium by creatinine ratio is more than 0.20, if it is high means increased urine calcium, calciuresis with loop diuretics. Loop diuretic is the mechanism. Loop diuretic means Bartter syndrome. Bartter syndrome, same mechanism. If urine calcium by creatinine is low, less than 0.15, means thiazide diuretics and Gentleman syndrome. So I will give a few examples. Patient has hypokalemia. And spot urine potassium is high, more than 20-30 milliequivalents per liter. This is metabolic acidosis. What are the causes? Hypokalemia. Spot urine potassium is high. Hypovolemia. Metabolic acidosis. What are the causes? Hypokalemia. Increased spot urine potassium is high, means increased renal loss of potassium. Hypovolemia, low BP. Metabolic acidosis. RTA. Simple. Proximal RTA, distal RTA. Proximal RTA with drugs, estozolamide, topiramate. Distal RTA, we should look for amphotericin drug usage. DKA. So hypokalemia, spot urine potassium is low. Metabolic alkalosis. What is the cause? Vomiting. Vomiting is the mechanism. Okay. What are the mechanisms of hypokalemia with vomitings? What are all the mechanisms? One is bicarbonature. Second mechanism, to retain H+. So again, there will be potassium loss of, in the vomitings also, there will be gastric loss of potassium. What is the potassium loss with vomitings? What is the hydrogen loss with vomitings? Chloride, how much? The hydrogen loss, chloride loss and potassium loss. Hydrogen loss will be around 100 milliequivalents per liter and chloride loss again around 120 milliequivalents per liter. Potassium loss will be less, 10 to 20 milliequivalents per liter. So potassium loss is less. So there are severe profuse vomitings, the continuous vomiting, then only gastric loss of potassium can cause hypokalemia. So one is gastric loss of potassium, second is bicarb accumulation. And third one is because of hypovolemia, secondary to vomitings, there will be secondary hyperaldosteronism. That secondary hyperaldosteronism will cause hypokalemia. So how do you manage hypokalemia? We'll give potassium chloride or potassium bicarbonate or potassium citrate. So suppose the patient has metabolic acidosis, hypokalemia with metabolic acidosis, then we'll prefer potassium bicarbonate or potassium citrate. If there is severe metabolic acidosis, severe hypokalemia with pH less than 7.0. In that situation, we'll give potassium bicarb or potassium citrate. Patient has cardiac arrest or circulatory shock. Potassium chloride is the main drug. In most situations, we'll give potassium chloride only. So, it's highly concentrated solutions, 1 to 2 milliequivalents per ml. Each ml contains 1 to 2 milliequivalents of potassium. Highly concentrated potassium solution. They're available in 10, 20, 30, 40 milliequivalents. We'll give 20 milliequivalents per hour. Routinely, we'll start with 20 milliequivalents per hour, depending on the case. So if you take 20 milliequivalents, routinely we'll give 20 milliequivalents of potassium in 1 hour. 20 milliequivalents in 100 ml of saline in 1 hour. But if potassium is very low, almost if it is 1.5 with ECG changes, then we can give 40 milliequivalents per hour or 100 milliequivalents, even up to 100 also. There are case reports, but without any significant side effects, we can give up to 100. There are case reports where potassium is given at high level. Mainly 20 to 40 milliequivalents per liter. So highly concentrated solution. 1 to 2 milliequivalents per ml means 2 milliequivalents potassium means it has almost 4000 milliosmolars per kg osmolality. 2 milliequivalents potassium in ml has 4,000 milliosmolars per kg, highly osmolar solution. So we'll give in only central veins only. Central veins with rate of 20 milliequivalents in 1 hour. Because another reason is mainly if we give 20 milliequivalents in 1 hour period, there will be time for redistribution of potassium. So intracellular shift of potassium, and there will be maintenance of total body potassium stores. So it takes time. So that's the reason why we will give for 1 hour. And another reason is, if you give potassium, if there is a catheter, central venous catheter in the up to the superior vena cava, if you give potassium 40 milliequivalents into the superior vena cava, if you give rapidly, patient can develop cardiac arrest also. There are case reports of cardiac arrest with high dose of potassium directly injected into the superior vena cava. That's the reason why we prefer 20 milliequivalents per hour. But in serious cases, we can give 40 milliequivalents per hour comfortably. The potassium phosphate solutions also. Potassium phosphate solution, they contain 4.5 milliequivalents of potassium and 3 millimoles of phosphate. So when do you prefer potassium phosphate? Especially in patients with DKA, if you give glucose infusion rapidly, then that can cause hypophosphatemia, increase phosphate entry into the cells. So if there is combination of hypokalemia and hypophosphatemia, then we can give potassium phosphate solution also. So what is the normal potassium, total body potassium? 50 to 55 milliequivalents per kg, means 15 to 70, 3,500 milliequivalents of potassium, the total body potassium level. 98% will be in the cells, only 2% in the extracellular fluid, means only 70 milliequivalents in the extracellular fluid. In the extracellular fluid also, in the plasma is 20 to 25%, rest is in the interstitial fluid. So in serum, there will be only 15 milliequivalents of potassium. Total body store is 3,500 milliequivalents. Extracellular fluid, 70 milliequivalents means 2% of the total body store. In serum, it is 15 milliequivalents. That is total value. 15 milliequivalent means 0.4%. Only 0.4% will be in the serum. So if there is potassium deficit, there is decrease of 1 milliequivalent of potassium. Suppose from 3.5 to 2.5. If there is deficit of 1 milliequivalent, there will be deficit of 200 to 400 milliequivalents of total body store. But if there is increase of potassium, 1 milliequivalent increase of potassium from 4 to 5 or from 5.5 to 6.5, there is increase of 1 milliequivalent of potassium, there will be increase of 100 to 200 milliequivalents of potassium. So with diarrhea, how much will be the potassium loss? What is the potassium loss in the diarrhea? What is the normal stool potassium? What is the normal stool potassium value? It is around 10 milliequivalents per liter, 5 to 10. The stool loss of potassium is 5 to 10 milliequivalents. Sweat loss is from 0 to 10. Renal loss is around 40 to up to 120. So normal stool loss is 5 to 10 milliequivalents per liter. In diarrhea, in secretory and inflammatory diarrhea, there will be 15 to 40 milliequivalents loss of potassium in inflammatory and secretory diarrheas. So 15 to 40 milliequivalents per liter. If there is 10 liters loss, how much will be the potassium loss in stools? 10 liters means up to 400. So in inflammatory secretory diarrhea, there is severe diarrhea, there is loss of up to 10 liters. Total body potassium loss will be 400 milliequivalents. So if there is loss of 400 milliequivalents, then what will be the serum potassium deficit? 1 milliequivalent. The loss of 1 milliequivalent potassium serum value, then there will be 200 to 400 milliequivalents loss. And one calculation is, for 1 milliequivalent change, there will be 10% deficit of total body potassium. Simple calculation is, for 1 milliequivalent change in hypokalemia, there will be 10% total body potassium loss. So from 3.5 to 3, potassium decreases by 0.5 milliequivalents. Then what will be the total body potassium loss? 175. Okay, because with 1 milliequivalents means 350. Total body store is 3,500. 10% means 350. With 0.5 change, it is 175. Actually, potassium chloride infusion, for the calculation also, we should know total body potassium stores.